Hi, everyone. My name is Jeremy Harper. I'm the Director of Research Enterprise Systems for OSU Medical Center. So today I'll be talking about a few different items about what kinds of tools we use for retrospective, prospective data collection. Some of it's going to be talking about that stage 4 Courtney was referencing over how do we actually push the envelope, or it was Courtney and Tim who were talking about how do we actually push the envelope, take us past just data collection and our standard use cases into the next. So I was told as I was sitting in the back that Amy Drake already covered I2B2 a bit. Did everyone get that presentation? Was everyone here for that? All right, so we're going to mostly slide through this. I2B2 is a fantastic client. We have it here at OSU. If you go on Buckeye Learn, you can take the training and you can have access. It does aggregate counts. We've populated all the patients who have been at our health system for the last 5 years that aren't actively prisoners or actively within our psych unit because they have special protections with the laws that govern our organization. If you can see the training on Buckeye Learn, you have access to I2B2. And you can also always email us at ccts-informatics@osumc.edu if you have any questions, or we're happy to answer. So the next one I'm going to talk about is our Quarry Initiative. So PCORI is the Patient-Centered Outcomes Research Institute. It has funded a network of organizations to compile all their electronic healthcare information into a common data model. So there are 20 patient-powered networks. So those are networks where patients have come together around specific diseases, specific problem areas, and they're a little different from what I'll be talking about. There are 13 CDRNs, which are mainly made up of hospitals and public health institutes, where we actually have clinical data that we can put into a common data model. So we are one of those 13. We're called the Learning Health System Network, which is made out of all these little red dots. Mayo Clinic's our center site. We work with the University of Michigan, Intermountain Healthcare, Mayo Clinic, and some other hospital systems. And what we've done is we've combined all our patient data into the same data schema. Out of the 120 organizations across the entire nation, this PCORnet, the network as a whole, has about 122 million individuals that you could be querying, and they published this back on April 15th just to start letting people know who can you actually query from this network. So you get a fair amount of information. You have a lot of capabilities. There's PedsNet that mostly brings in our under 18 population, and then most of the other hospital networks focus on this category, so you can see it's bolded a little more. So we all operate through the Smart IRB. Smart IRB is the new protocol that every university using PCORnet has signed up on. You can submit through the Smart IRB website a protocol, and it can be centrally managed. One IRB can approve it, and then everyone else can just accept it. And so you don't have to keep resubmitting IRBs at each institution for the PCORI network. It does expand beyond just PCORI. So the CTSA also funded and pushed, and every CTSA site also signed on to Smart IRB. So it's something to take advantage of if you're looking at leveraging a multi-center study. It provides a single point of entry for the reliance process. You upload all your documents once, and then you don't have to keep uploading documents. And it'll guide you straight through a workflow and help you communicate to each of the institutions that you're working with on a multi-center study. So the PCORI Common Data Model. In this, there's no front end for this at the moment for regular investigators to access, but we have a governance model where if you have questions that can be answered by this, you can ask this at both Ohio State and NCH, You can also ask it for the Learning Health System Network, so Mayo, Intermountain, academic medical centers, basically. Or you could ask from the full 120 organizations around the nation through the PCORI network. In it, for Ohio State, we have all 800,000 people who have been seen at Ohio State in the last 5 years since we went live with Epic. We've got their demographic information, every encounter that they've had, the diagnosis codes, prescribing, lab results. So we actually have had to load every lab that anyone has ever received into the lab table recently. And then what makes it special is PCORI also funded us so that we pull in data from our health plan. So we have people who, I'm a health plan member for Ohio State Health Plan, and so I am in this chart, and every time I've filled a drug and they've helped with copays on the dispensing, they have all the dispensing information. So they can see how compliant I am and do outcomes research with that as well. I don't believe they've published how many people are within the total insurance information tables. I know that the LHSNet, the Learning Health System, had 1 million people that we contracted to when we signed up as a network, and we hit that number. Yeah.
Just going back to the drug dispensing.
Sure.
Where do you get that from? How do you get?
So the health plan itself transfers it to us.
So that's for only those within the OSU health.
Only within the OSU health plan.
So if someone was insured through a different plan, you don't get that.
We don't get that now. Some insurance providers have been very interested in partnering with PCORI networks. Some have not. Different networks have different data. So some of it winds up like Blue Cross Blue Shield. They're separated into their own individual networks around the nation, and different groups have been very interested in working with partners. Different groups have not. So it just depends. If you have any connections to any of those groups, we'd be happy to work with you to work with them to get the information if they're interested in it. So all 800,000 patients into a common data model, it's something that you can start doing research with, asking questions, and if you design your questions around what data is within this PCORI data model, you're also able to then expand it and make it multi-center in a very short order, much easier step rather than having each organization go in and try and build a custom query for their Epic database or their Cerner database or Allscripts or anything along those lines. One of the things that they touched on very briefly is there's a lot of work involved whenever you're working with a multi-center study. Trying to convert from your different electronic healthcare records into the same question. You have to write different queries, reference different tables. Within our Epic IHIS instance, there are 16,000 different tables. And so what we've done for this PCORI data model is compress it down to 10 tables that are the most useful for answering research questions. Then all that happens is this is how the data gets transferred. If you're asking a question from the larger organization, you submit it to the central organization. They send it out to every site. Every site runs that query against the same data model. They review it manually, and then they upload it back if you have permission to actually see that information. It's a very streamlined process and can actually start answering questions fairly quickly. PCORI has funded a few different studies that have been leveraging the network. The Adaptable Study is asking questions over whether or not you should have, which of the 2 aspirin dosages is better for heart failure, not heart failure, that's a different study, but anyway, it's for people, I can't read both slides, heart attack or stroke, does it reduce your risk? And it's actually trying to answer that question. So we're actively recruiting sites around the nation for this study, but prior to that active recruitment phase, we were able to leverage the network to answer questions surrounding how many people at each network site are there actually available, so that you can actually say, okay, we see 10,000 people a year at Ohio State, we see 15,000 a year at Mayo Clinic. You set different targets for how many people you're going to recruit at each site, and you're able to actually build a better study. And so the next thing I'm going to talk about is Research Warehouse data requests. Courtney was starting to touch on this. Thank you, Courtney. So the first slide I'd like to show is just to tell you where the data lives, how the data lives. Before you can even come to us and ask for the data, you have to somewhat understand where it is, how it is, and so that we're pointing you in the right direction. So we have an IHIS clinical box over here on the left-hand side for all of you. IHIS clinical is what physicians, the nurses, all your staff members who are helping in patient care are entering in. It's hyperspace. The moment that you enter in any data at CarePoint East, it's available across the entire health system instantly. That system runs on an esoteric database structure called InterSystems Cache, and it's not very flexible for querying across time. It's very good for transactional data telling you about the specific encounter you're dealing with. So every 24 hours, we move it over to what we call IHIS Clarity. So that's a SQL database. That's what you're more familiar working with. That's the 16,000 tables, and think of each table as a single Excel document that could have 0 to tens of millions of rows within it. Every 24 hours after that, we move into our information warehouse. And so that's where we have all our historic data, as well as a number of tertiary systems, and we are able to put all that data into one single location. So depending on the questions that you're asking, depends on what data source we go to. If you're asking for help recruiting and you can't wait 24 hours, we have to build it within our IHIS clinical system. If you can wait 24 hours and get a daily report, building it off of our Clarity system is something that we can turn around much more quickly, and it's something that we've got teams of people who can help you with. And then the same for our information warehouse. So here at OSU, as a researcher, you go through our honest broker process for any data that you want to request, whether it's clinical encounter, demographic, lab results, order entry, radiology images. All of this is stored within our electronic medical record and our information warehouse, and our honest broker group governs that. So the honest broker is a protocol to the IRB that tells the IRB exactly how we vet and we work with our researchers to deliver data. Because just because you have an IRB does not mean the medical center also agrees that you can have that data. The IRB often approves things that the medical center puts certain restrictions around. We had an IRB requested from the Honest Broker Committee as an example, where they were asking for payer data so that they could publish, here's how much each payer reimburses. And that actually violates contracts for us. And so the medical center denied that data, even though from an IRB perspective, it was a fine research project. And so the medical center had to work with that investigator over what could they actually publish and share. Within our Honest Broker group, we basically deal with 5 different data types. Aggregate count requests and de-identified requests never require an IRB. So if you just want to know how many people meet certain criteria, don't go and build an IRB just for that. You can make the request through CORE, and we can start answering those questions. There are always those areas that are a little more sensitive. For our aggregate data count, we have a small cell count of, it has to have at least 25 individuals so that there's less risk of re-identification. De-identified means that we are completely de-identifying. You have none of the 18 elements of PHI, and we skew all the dates, so it could be plus or minus 60 days. but it's the same plus or minus 60 days for every encounter that I am as an individual. So if Jeremy Harper came in to this database, you might skew me by negative 25 days, and if Courtney Hebert was in, everything would be skewed by negative 5 days. So you can't just re-identify by the dates of encounter, but you can still run your queries and data over it. Limited data sets sometimes require IRB, sometimes don't, depending on exactly what elements you're requesting. Identified data sets always require an IRB for the institution, and imaging requests, we bucket those in their own special request type. I see some folks with our imaging team in the room. They still have de-identified and identified that we do and can support. So our Honest Broker group is made up of lots of different areas of the organization. It comes together every Monday for an hour, and we meet over every request that's been submitted. So going through this process is far less time consuming. You don't have to wait a long time for it to be reviewed and to get feedback. And the whole purpose of having this group together is to protect our patients, protect our organization, but to turn the data around for you as a researcher quickly. In the past, we did have situations where a researcher would request something, we'd get halfway through it, and then someone would find out about it and say, wait, hold on, there's a red flag. So instead, we now bring our HIPAA privacy officer, our legal team, our information warehouse, James Cancer team, our quality team, our research team, and our imaging informatics all together once a week to go through every request. So we do turn these around very quickly, and we work with you if we have any items that we table. We always table and go talk to the investigator before we deny to try and figure out whether or not there's anything that we can do to help you accomplish your research. All of this I already covered. In short, there is a process for you to request data from the information warehouse. It has all 16,000 Clarity tables that we can access. If you have any research information that you're interested in, you just go into Core, create a project, and then hit the blue button and submit a request specifically to Information Warehouse, and my team will help you with putting in the request. Also, as an FYI, we now have you hit the blue button in Core, create the Information Warehouse request. We generate a new form in REDCap that has a lot of specific questions about your IRB protocol. We also have you upload a copy of your IRB protocol because we do review that every week for every request. If you do have clinical information warehouse service questions, I threw the OneSource link on there just so that you have that available when you're looking at this slide deck. And so with that, John, I think I'll go ahead and turn this over to you, and then with whatever time we have left, I can cover some of the IHIS stuff.
Okay. Jeremy?
Yeah.
Just one question about ITP2. So it appears that the current version, we don't have the NLP functionality.
We don't have NLP into it, no.
But the new version release has NLP. Are we going to get that here or not?
It's not currently on the roadmap to implement that.
You mean here?
Not at OSU. And unfortunately, ITB2's offered it as a support capability for a little while. It's just not been something we've done at OSU.
Yeah, I think when I spoke to Amy previously was, we actually get this because, other places they have it running, and some of us who are using NLP that
Sure.
would really help us a lot. So we could just go in there and apply straight away, and not having to do it at the back end.
Sure. So
Speak to someone else?
you can speak to me. I'm helping manage that now. It's not on any of our roadmaps, and right now my roadmap is to get the ITB2 system upgraded to the latest version. But I'm happy to talk to you and see if we can't build a use case and a legitimate argument for investing the time and resources for that.
Thanks, Jeremy. Hello, my name is John Thompson. I'm the senior systems analyst for bioinformatics, and I'm going to talk to you about Scarlet today. Scarlet is a database browsing software. It's designed to show you what you can find in your database. When I first started this project, we had a fairly technical way to go through your database, and it was great. You could get just to about everything you wanted, but you had to be technical minded and you had to be able to do a little coding. And a lot of researchers just wouldn't use the tool. So the challenge with Scarlet was to make something that was user-friendly, that researchers could easily go into their database and find out what's in there and what kind of stories their database can tell. So we made it simple English instead of computer coding kind of language. We made it drag and drop to start your queries. And there were a lot of tables in your database. When you put a database in set it up and running, there's a lot of extraneous data tables in there, and the researchers found those confusing, so we got rid of those. We made it possible for once you find your information with your query, you can save that to a library and reuse it, and you can also share it with your research team. And it is a browsing, kind of browse your database software. So once you get your information, when you found it in your database, and you really want to then explore it, you can export the CSV file and bring it into a fully high-powered analytics tool like SPSS or SAS. Thank you. So I'm not going to go over the architecture. I think Omkar did that a little bit. What I'm going to do now is, when I was looking at the database that we have, and what Scarlet was developed for was going and taking information from IHIS and patient information, and it just kind of, I was looking at it, and it was just a bunch of numbers, and I decided to simplify this and turn it into a story, basically, and the story starts with the person. So in the database, you're basically trying to model a person. What is a person? And this person in our database was pretty simple. It had a day of birth, month of birth, year of birth, race, ethnicity, and gender. So we said, okay, that's good. And this person had a condition, obviously, because he's in our IHIS database. So they're going to have a condition, and that condition, the model for that is pretty simple too. It just has a name and a start date and end date for the condition. And the person with the condition went to a care site here at OSU, and the care site has a name and a place of service. And in that care site, there is a provider. And again, a pretty simple model for a provider. And that provider can do medicines, and when the person goes there, they create a visit. So this is all in our database. And once you turn it into a story, it's pretty simple, but it gets a little complicated. We've got a fairly, starting to get a complicated little web here of what's going on. Procedure is also something the doctor can set up. So what we have here is the relationship, because this is a relationship database. If this were an Excel spreadsheet, all of these little sections would be one spreadsheet. But in a relationship or relational database, these spreadsheets know how they're connected, right? So if you start with a person in the database, you can see its connection. It's connected to the provider, to the condition, the medicine, a procedure, a care site, and a visit. And obviously from this, you can kind of see that this database is a person-centric database. So and that's your patient, right? So that makes sense. And if you can see that a provider has fewer connections. It's connected to medicine, labs, and a person and a care site. So now you can kind of see how things are all related. And that's what we wanted to show in our database. Now for computers, computers like numbers. So in addition to our human readable information, we also have a number here. So this is a number that's very much like your index number in your Excel spreadsheet. But this is what tells the computer the relationships. So they look for these index numbers, and that's what connects the relationships to the computer. And so everything has an ID. And that's what the computer uses to make these connections. So Scarlet is supposed to be intuitive and user-friendly. Here's the URL for it, and you log in with your OSUMC ID. And when you get there, you get this view. You get an overview of simple overview of your database. So this has 208 people in it, and the gray is male, the red is female, so you can kind of see how that breaks down. And then if you just click on the simple queries, here's our advanced queries. So if you do have technical abilities, you can just go straight there. And here's our layout, and we bring in these little icons that you saw from the story. So you can easily see what you want to, all the little elements in your database. And when you click on these, you can expand them, and you can see their attributes in here, the little things we use to model. And then you can just drag and drop. This is a slide, so I'll pretend like I drag and dropped. And you can drop it right in here. And then it'll give you this option to type in information. You can do equals to, less to, greater than. And this is the ID number. So that's the computer number. And if you set it to is present, it'll show you everything, every person that's in your database, right? That'll just give you a list of all the people in the database. And then here we have this option here of what columns you want to see. And so basically for the person, you can select all of these options to show. And then you can get your results. So here are all the people. This is de-identified registry. And you can see we selected year of birth and race. So then you can add other things like medication. So now we want to see all the people in your database with a medication. So you just drag over a medication and start typing, and then we'll autocomplete for you. So if it's in your database, we'll show you all your options here, and you can just click one, and you get the medicine that you chose, and then you can choose the columns you want to see. Now you see medication is an option in your columns too. So you can select the medication, number of refills, medication start date, name, and now you get all these results in your table. So, and if you want to do, a lot of times if there's if there's anything in your table that is new across the row, then you'll get repeats. So like if there's multiple doses of medicine, you'll get that same person several times because you have multiple doses. So we put in this do not show duplicates row, and that way you get fewer results but less duplicates for in your results table. And what that's good for is if you want to get a count of the people. So you can do your list of people and their medicine, and then you deselect all the other rows that you don't want to show, just the person ID, and that'll give you a count of how many people are on that medicine. If you have the medicine there, there's lots of different doses, so you'll get a false count. They'll get a count for every time they have a different dose. So that's the way you get a cohort or the count of the people. Let's see. Oh yes. Oh yeah. And you can save your result, or you can. So this is for butyrol, and you can just save that, and it'll go into the query library, and you can share that. Here it shows that I've shared this other query with my cohorts, and this goes to everyone that is an active user in your registry. And we also, so that's from IHIS. Jeremy, do you have a question?
Not as much a question. I just wanted to make sure we were tying this back in for everything. The Scarlet platform, as John was saying, takes the 16,000 clarity tables down to the 8 OMOP tables, that person matrix that John was showing. The beauty for it, for your research, is once a week we refresh this database every Sunday. And so anytime that you have registered someone on your research protocol, that means that next refresh, we pull their entire life history into this database. It also means that for everyone that you have registered on your research protocol, we pull any additional information. So if they've had a visit in the last week, it all comes into the database. So you can compare the same queries week after week. You can see what's going on. You can see trending. But that's how it ties back to your research protocol. It's really intended for that long-term research registry use of what's going on as a whole for a patient population. The front end that John's demoing also has the additional capability of it's flexible. It can point at any MySQL database and give you the same drag and drop interface. So if you have other databases that are not based on the Epic EMR, that is not this research registry platform where we pull everything from Epic and drop it down, talk to John. He can walk you through what it can do, how it can do it as well.
And that's a good segue to the Foundation Medicine. So Foundation Medicine came to us, and they had a database with cytogenetic information in it, and it didn't follow the OMOP database plan. So we said, sure, Scarlet is it's just a user interface, and it can connect to any database. So we loaded it up, and here's all their information. So they've got everything that's dealing with cytogenetics of a cancer patient. And let's see, we have person here again. So still, you connect to your person, and you can select the columns that you want, drag over the information that you want to search, and get your information. Now let's see. I'll go back. So as you can see in the results table, here are all these columns with null in them. This is what I was talking about, hiding the columns that you don't want. So in this database, we just brought it in from, I think from their Excel spreadsheets, and they had a lot of these columns that are empty. And so that just kind of messes things up. So what we want to do is if you go into maps, you can actually rename the columns. So here are the columns as the database refers to them. So the titles across your Excel spreadsheet. Now sometimes those are made by IT people or someone and they don't quite make sense to you. We have this mapping in Scarlet that allows you to rename it, maybe a little more simple, more intuitive name. And you can also turn off the names of these columns that don't have anything in them or you don't want to show. And also in Scarlet, we have this dashboard here that gives you an overview of your database. And here we have the age range of people with hairy cell leukemia. And you can see, it goes 65 and starts to go down as you go to 80, 89. And so you can read a story in there too. And then this is for vitals, and you can kind of track the patients. This is a patient. This is the index, not their MRN. So this is an index number. And you can kind of see their vitals here. But what this dashboard really is if you come to us at Biomedical Informatics and ask for a special, you want some visualization for it, we can work on that with you and add it to your little cards here. And so you can have that to kind of go in, like Jeremy said, every week, every Sunday, we refresh your database. You can go back and look and check out your widget and see what the status is of your database is. And registries, like Jeremy was talking about, is what this runs off of, or what it was made for. And it can do other things, like we said, but it was made for our registries, and so it does IHIS and REDCap and custom sources, like I showed you. And you get unlimited data access, like Jeremy was saying, refreshes every week. You can get identified or de-identified data, and it's secure behind the OSU MC firewall, and you have access control. You can say who has access to it, and that's, you get your IRB and yes, and then, yes, you give that to him. And so if you decide that's great, I want one, this is kind of like the timeline for how long it will take to get in the registry, for the registry. Much quicker if you just have your own database and we put a scarlet face on it. Yes. So the primary investigator gets an idea, and they want to formulate an idea for making a registry. A good idea is to come to us and talk at this point, talk to Jeremy, and we'll guide you through, kind of work with your idea, let you know what's possible at that point before anything, is uploaded or forms are filled out.
Spend too much energy on the impossible.
Yes, exactly. So come see us first, and then you can start your registry. Jeremy talked a little bit about going on to Core and setting that up, and that takes about 1 to 2 weeks. Jeremy said it was pretty quick. So.
Really, it just winds up, how soon can we get in person into a meeting? My schedule is always up to date, and so it usually winds up being trying to mesh out your schedules. But usually we get it within a week. When I'm lucky, I get there the next day.
Okay, and then you sit down and plan your project, and you can add add helpers to your project, like Jeremy.
You can take advantage of CCPS, the IRB experts. You can take advantage of Rose Halloran, who's an expert on what type of recruitment you might be leveraging. For the research registry platform, you're going to want to pair it with some type of planned recruitment. The IRB has traditionally, for anything that is going to be a lifetime commitment over being able to access their data, they want someone to be there in person to talk you through what you're actually committing to and making sure you're consenting and you actually understand what's going on. That may not be the case forever. We're talking more and more about how can we do this and proactively educate our potential research subjects in a safe and open access way for electronic signatures and that type of thing. But for the majority of these registries, they have a research coordinator in person talking through consent.
And that's a little bit of the consulting there. And then you submit your IRB, and that takes 4 to 5 weeks. Is that still legitimate?
They've been moving faster than ever, so
Good.
IRB approval is doing really well lately.
Okay, excellent. And then when you get your IRB approved, then we can set up the registry, and that is, and that's what. That is old. Yeah, that's
We
pretty quick
turned
now.
that around much more quickly now. It's a very streamlined process.
Yeah, that's almost like a couple days.
For the last 3 registries, we've actually waited longer from the technical perspective. We set everything up, and then they haven't consented anyone yet because
Yeah.
they're still training the research coordinators. So our setup, Harper's in the back. Would you say it's 2 to 4 weeks now? Yeah. So no
Yeah.
more than that.
Yeah. Okay. So this is where I normally do a live demo, but now I will just take questions. Yes.
So between Scarlet, can you talk a little bit more about which one?
If you want to use Scarlet and the registries for something if you have ongoing project where you're pulling more and more consented patients into your project and doing more research. So because it refreshes every Sunday and it's a live continual database, that's the.
And I think the key for us is at OSU, we only use IQB2 for aggregate counts. This gets you to line level detail with the Scarlet platform.
Yeah.
One more I can kind of differentiate is practice or practice. Scarlet, you can add more resources as well to your database. For instance, if you're gathering patient-reported outcomes or whatever in RedCap, you can kind of merge that data from your IDIS pool to this Scarlet. If you have like another custom data source, you can kind of assemble that data within Scarlet as well.
I also wanted to mention that in the future, what we're working on with Scarlet is to handle big data. So right now, we have a little problem with big data, but we are working on that. So when you have millions of samples and cytogenetics, we can handle that easily.
Any other questions?
Yeah.
So we have an ETL that extracts the data from IHIS and pushes it into Scarlet, yes. Typically, the data that you receive from the information warehouse is on a single spreadsheet or maybe 2 spreadsheets, and this platform isn't going to be useful for you. It's only when you're trying to relate lots of different data tables. We can absolutely work with you, though, if it's something you're interested in and leveraging it for that. So the Total Cancer Care Protocol has Orion, and they've got a different platform that they've custom developed to give access to their data. Not at this point. We work with Nancy as well, and I know Nancy was here earlier today discussing it, the Total Cancer Care, and I'm presuming she mentioned Orion. Rob, I'm sorry? So if you want to reach out to Nancy Single, she can walk you through Total Cancer Care's plan and vision for making that data accessible. Our team works with them, so we know a lot of the technical details, but she can actually talk to you about what's the vision for making that data accessible. This is absolutely useful for retrospective. It just winds up come to us with your use case, and we can talk through all the details over whether or not this is the tool we'd recommend, or if we'd recommend another tool. We have a number of different tools. Big retrospective studies, we might recommend Scarlet. We may also recommend that you work with an analyst to build a specific query for your specific question. Some of it also depends on what do you have permission from the IRB for. A lot of retrospective studies, you are looking at specific elements and you're not going fishing. And a number of these research registries are more in the fishing vein of, we want all the data because we don't know what questions we will wind up asking. We will go back to the IRB to ask permission to ask those questions with upcoming protocols. So they kind of separate out their recruitment and registry work from the question that they're asking specifically. So for the research registry platform, there's a $10,000 the first year, and then $1,200 a year after that, and the $1,200 just covers server costs at the medical center. The $10,000 covers the time and energy it takes us to help you get from idea creation through implementation, so that all this data is coming in, and we cover some, and Amkar can be more specific, I'm sure, in the back, we've built in some hours to, we have yet to have a research registry that isn't working with REDCap to collect additional data elements that aren't captured in IHIS. And so we're merging those two data sets, and that does take some time on someone's part. The CCTS still subsidizes that as well. So the initial cost was significantly more, and they've been subsidizing it for the last 2 years. Yep.
Okay.
Any other questions about research registries?
Yeah, you mentioned that you can get either identified or de-identified
Sure.
data. But what's your consent around that? Like, where people would consent that their data be identified?
So de-identified is a little different, and Amkar can speak more to this because he was much more in-depth part of the process for the de-identification creation. The intention that I understand it was you identify your cohort, say these ICDs or whatnot. We'd be able to apply the ETL, convert everything from Clarity down into a de-identified data set, and then it would remain static for you. Because the IRB frowns on us giving you a different de-identified data set every week, because suddenly you can start rematching it to individuals because they visited, and they're the people with 5 diseases that are relatively unique.
And just one more point you mentioned.
Yeah.
As far as the identification is concerned, we would be leveraging the honest broker protocols as implemented by the institution
Sure.
for the identification. So we would kind of stick to their standards.
But that would be a way of getting a lot of data very quickly, if you're interested in it. We've also had some investigators where they wanted to be able to share with other multi-center studies, and they didn't want to have to go request us to de-identify each time, and so they requested that they just have a side-by-side. So they have a research registry that's identified, one that's de-identified, so that they don't have to generate this each time they want to share the data. But that's all covered in their protocol to the IRB in the first place. So,
All right.
thanks, John.
Take it away.
I don't have that much more to cover. I did want to mention that we do a lot with our IHIS, our electronic healthcare record, to try and move the needle on how do we leverage it in a way that it wasn't designed for to actually move research forward. So if you're interested in doing new and novel research within the electronic healthcare record, come talk to me. We can talk about how you can capture data discreetly so that it can actually come back and be something you report on later. We can talk about how you can drive new workflows and the process in place for the medical center for getting that approved. We talk about protocol adherence. Oh, well, that's interesting. I have no idea. Look at the side. I just saw the one in the back. And, these are just buckets of things that we've found that lots of investigators across the enterprise are really interested in and helping do and enhance their research. Whether it's protocol adherence, so if you have a very specific protocol, we've seen this used most in our stroke program because they have protocols where they give certain drugs in 5-minute increments, and they have lots of different team members that come into play, and they want to coordinate with everyone. If you're wanting to do subject recruitment, we have clinical trial alerts that can pop up for clinicians, alerts in the background of the system that can page your research coordinators. We've dabbled with MyChart recruitment, and Mike Para and Rose Holleran are leading a new effort to get approval to do much more broad-reaching MyChart recruitment. And then we do have release a number of different reports that help you actually keep track of the subjects that you have and improve your retention rates. If you can schedule someone who is already going to be here on site at the medical center for a doctor's appointment to also follow up for your research protocol, that does improve your retention rates. And so with that, I'm going to say that's the end of my presentation. Thank you all so much. If there are any questions, start shouting them out.